Welcome back to Core EM, the official podcast of the NYU Bellevue Emergency Medicine Residency Program. I'm Bree Tse, here with Joe Offenbacher.
Hey Bree, I thought it might be a good time to review some bread and butter topics in the diagnosis and management of common metabolic derangements, hypocalcemia.
Definitely. To be honest, Joe, it's not something I see all the time in the ED, so a quick primer would be great. Did you know that calcium is the most abundant metal in our body?
Wow, nope, that's a fun fact.
Yup, it's pretty important. To keep things simple, let's focus on hypocalcemia in adults only for this episode.
Deal. To start, let's quickly review some general calcium metabolism.
Great. So, this was a really big chapter during med school, but not something we revisit in detail too often in the emergency medicine room. So, remember, there are several physiologic systems that contribute to calcium metabolism and plasma levels. These include 1. The endocrine system. PTH is released in response to low serum concentrations of calcium. 2. The GI system, which enhances absorption of calcium from the intestine in response to vitamin D. 3. The renal system for calcium resorption. And finally, the skeletal system via bone deposition, resorption, and calcium efflux.
Nice. Without going into too much detail, it's worth noting that the etiology of clinical hypocalcemia is often thought of in 4 broad categories. See the show notes for the up-to-date table, which include, first, low parathyroid hormone hypocalcemia, usually due to a primary parathyroid gland dysfunction or destruction. Second, high parathyroid hormone hypocalcemia, which includes disease processes related to vitamin D resistance, PTH resistance, renal disease, and excessive calcium diuresis or removal from circulation, due to diseases like pancreatitis, tumor lysis syndrome, and sepsis. Drugs treating hypercalcemia, as well as those that have side effects impacting blood calcium levels, such as phenytoin or calcium channel blockers.
And the fourth, hypomagnesium can impact PTH levels and therefore serum calcium levels.
Exactly. You should be aware of specific etiologies of hypocalcemia, including hypoalbuminemia, as calcium is most commonly found bound to albumin, chronic renal disease, concomitant conditions leading to phosphate and magnesium derangements, TLS, rhabdo, and other processes that lead to cell destruction, hydrofluoric acid burns, it binds to calcium and magnesium, which can be fatal, and perhaps, most famously, hypocalcemia secondary to calcium chelation during massive blood transfusions.
Great. So, basically, several organ systems are involved in calcium metabolism, and as a result, many disorders have processes that set off and or propagate hypocalcemia. In terms of clinical presentation, symptoms will vary with the severity and degree of hypocalcemia, but even more important than severity is the rate at which the condition develops.
Really? How so?
Well, the most important factor in clinical presentation is the acute versus chronic nature. Acute hypocalcemia will tend to present differently than chronic manifestations.
Okay, so tell me first about chronic hypocalcemia.
Chronic hypocalcemia leads to calcification of the basal ganglia, leading to Parkinsonism and extrapyramidal type of syndromes. These patients will also commonly demonstrate dementia, cataracts, dry skin, and possibly distorted dentition.
Okay, wow. Those last 4 symptoms would seem pretty unrelated right off the bat, but tying them together due to hypocalcemia makes a lot of sense. So the textbook symptoms of tetany, paresthesias, papilledema, seizures, laryngospasms, and bronchospasms are all acute manifestations?
Exactly, which explains the trousseau and chopstick signs. Not that we're necessarily doing them in the ED, because calcium levels are pretty quick and easy to get.
Right. Those signs are due to neuromuscular irritability. And with those come all of the cardiac manifestations as well. Prolonged QT, hypotension, heart failure, and dysrhythmias. Okay, so once we have a suspicion for hypocalcemia, how is it diagnosed?
Just basic labs and an EKG, Joe.
Awesome. By definition, hypocalcemia is defined by a serum calcium level of less than 8.5 milligrams per deciliter, or an ionized calcium level of less than 2 milliequivalents per liter.
Right. And remember, importantly, that calcium exists in 2 states. 1, bound to proteins, most commonly albumin, and 2, unbound, in a state known as ionized calcium or free calcium.
Exactly. And this is relevant because even though ionized calcium is an absolute value, serum calcium levels often need to be adjusted in cases of concomitant hypoalbuminemia. Look in the show notes for a link to Swami's 2016 Coriam post for the formula, among other pearls.
Always remember that calcium, especially free calcium, plays a major role in muscle contraction, both smooth and skeletal, clotting factors, and nerve conduction, which actually all makes sense in the context of all the symptoms that people can develop.
Exactly. Free calcium is also inversely related to serum pH, so patients often develop an alkalosis. Don't forget that obtaining an EKG is critical.
Good tip. Okay, Joe, let's move on to management of hypocalcemia in the ED.
Absolutely. So the management should be tailored to the degree of symptoms and the severity of clinical findings.
Mild to moderate symptoms should prompt oral repletion with either calcium carbonate or calcium citrate, and these patients can often be safely discharged with prompt outpatient follow-up.
For more severe cases, IV calcium gluconate or calcium chloride may be required.
IV calcium supplementation with 100 to 300 milligrams of calcium raises serum calcium by 0.5 to 1.5 milliequivalents. Despite differences in administration, calcium chloride can be caustic and should be given through large bore IVs or central line. There's no difference in bioavailability or rates of calcium repletion between these two formularies, so you can choose based on what you have on hand as well as discussions with your pharmacist. For acute but mild symptomatic hypocalcemia, you can give 200 to 1,000 milligrams of calcium chloride IV or 1 to 2 grams of calcium gluconate IV over 2 hours in the ED. For severe symptoms such as seizures, the dose is 1 gram of calcium chloride IV or 1 to 2 grams of IV calcium gluconate over 10 minutes for both, repeated every hour until symptoms resolve.
Exactly. And remember, patients with severe hypocalcemia should be in a monitored setting, as bradycardia, hypotension, and other cardiovascular manifestations are common in these patients.
And make sure to replete that magnesium as well, and don't forget to consider prophylactic calcium repletion in patients undergoing large volume blood transfusions. The bottom line is, be sure to treat the underlying disease.
Awesome. Ready to do some take-home points?
Sure, I'll start us off. So 1, hypocalcemia can have several etiologies, and its clinical manifestations are often the result of the rate of developing the metabolic derangement.
2, remember to consider both serum calcium and ionized calcium levels. Don't forget to correct serum calcium for hypoalbuminemia.
3, remember that treatment should be tailored to severity of symptoms and clinical manifestations. Also, remember conditions where hypocalcemia can be anticipated, such as large volume blood transfusions, and treat the underlying disease.
4, and lastly, ABCs are really important. These patients can have hypotension, bradycardia, or laryngospasms. These patients should be on a continuous cardiopulmonary monitors. In addition, large bore IV access, even central lines, may be helpful in rapid repletion of calcium chloride.
Great. Well, that's all for this episode. Continue to follow us on Twitter at core_EM and visit us on our website, coreem.net. Thanks for listening and stay safe, everybody.